Start the session.
Hello and welcome to the 63rd session of Pediatric Orthopedic Active Learning Sessions. The aim of these sessions is to encourage young generation to think logically and manage the difficult cases efficiently and with confidence. It's my privilege to introduce today's esteemed speaker, Dr. Andrew Georgiadis. He's from Gillette Children's Hospital, Minnesota, USA, a very popular premier center in USA. He has done a fellowship at two premier institutes. The first is Children's Hospital of Philadelphia, CHOP, and the second one is Royal Children's Hospital, Melbourne, Australia. The topic for today's session is management of congenital pseudarthrosis of tibia. Again, I call it a difficult to treat condition because results are not 100% unlike many other pediatric orthopedic conditions. However, the results are much better today than it was before. And this time, instead of didactic lecture, we are going to have a few selected cases, the difficult cases for the discussion. And I am very happy to welcome Dr. Sandeep Vaidya from Mumbai, who has also a vast experience on this topic. This session will be moderated by Professor Hitesh Shah, again, who has published a lot and again a vast experience on the CPT. Before I hand over to Hitesh, I would like to thank OrthoTV for its unwavering support to this academic initiative, which aims to mentor and groom young pediatric orthopedic surgeons, not only in India, but worldwide. So with that, I request Professor Hitesh to take over. Thank you.
Yeah. Thank you, Dhiren bhai. Thank you for the invitation and arranging a good session for our postgraduates as well as the fellows. The fellows would be benefited, and this is one of the difficult talks, the difficult topic for the understanding and treating the cases with pseudoarthrosis of tibia. So my screen is visible, Dhiren bhai?
Yes. Yeah.
Yes. Okay. We will go on directly on the cases, and we'll start with the first case. This is the 4-month-old child, parents brought with the deformity of the both side tibia. The child has got multiple capillus spot, and the family history of NF was also present. So there is no ambiguity in the diagnosis or the NF1 with one side frank pseudoarthrosis and other side is the anterolateral bowing of the tibia. So let us start with the anterolateral bowing of tibia. It's like the topic of discussion for the first. So if we see the anterolateral bowing of tibia in a child with NF1, what should be the approach in that? That should be the consideration. The first question to the Andrew, it's what should we do at the 4 month of age?
Hey, thank you for the question, and thank you again for having me in the discussion. I look forward to learning from everyone. I don't think there is a widespread consensus about how to treat a pre-fracture anterolateral bow. I think there's heterogeneity of treatment. This is a very young child for diagnosis, but if it is pre-fracture at my institution, we would treat this with guided growth. So we recognize that there is a complex three-dimensional multiplanar deformity at multiple sites. So we see actually procurvatum of the proximal tibia, there's some diaphyseal procurvatum, and then the anterolateral angulation in the distal third, and the fibula is intact. And so the youngest child in which we've employed a distal anterolateral hemipiphysedesis has been 8 months of age. And so I think just like pseudarthrosis or non-union treatments, you need to have a tibia, distal tibial physis that's large enough to accommodate whatever implants you're going to use. But that would be my first treatment for the child's right tibia is anterolateral distal guided growth. And I would probably wait until the child was a little bit older, like closer to pulling to stand, and I would protect it until that time.
Okay, thank you for the stating that the 8 month is the youngest. So the question that while we're waiting for the surgery, would you give it the brace, and what kind of brace in a child with the 4 month of age?
Yeah, in a very young child, it is very difficult to brace. So I would begin talking to them about a clamshell short leg solid ankle foot orthosis. I think that it might be early to do it 4 months, but around 6 months, I think that you could get a good fit and use that most of the time.
PTB, above knee, below knee, what?
I've been using just below knee without
Okay.
PTB, and that's been satisfactory.
Okay. The another point we'd like to highlight that you mentioned the fibula is intact. Would you consider for the treatment plan whether fibula is intact or fibula is also involved in having pseudoarthrosis? If the same child will have fibula is not intact, would you change your plan or strategy?
I would not change my plan based on the status of the fibula at this young age. If I felt that we were pre-fracture and amenable to guided growth, I would pursue the guided growth independent of the fibular anatomy, because I don't know the fate of that fibula if it's intact. Sometimes we have seen resolution of those dysplastic changes with the changes in the tibial anatomy. And other times we have seen that not resolve. We have seen maintenance of that fibular deformity or even fracture of the fibula during the guided growth. And so because in this case, I don't know the fate of that fibula, only considerations about preserving fibular growth will remain, but I would deal with the fibula after the tibia is corrected. And if it was fractured or there was a pseudarthrosis of the fibula, I would do the same thing. I would deal with the fibular pseudarthrosis once the tibia is corrected.
Okay, because the fibula pseudoarthrosis, the natural history will drift into valgus. Well, the intact fibula with anterolateral bowing would be going in varus. So that's why we put the plate on the any growth modulation or anterolateral aspect. However, in the Jennifer's Lane paper, because the number is very less, they did not identify the factors between fibula is intact or fibula is abnormal, because that will dictate about keeping the growth modulation, how long and whether to overcorrect or undercorrect or not. That is another issue for the anterolateral bowing of tibia. So do you think so it is a important points, or how many were that fibula was intact or fibula was affected in that your series? Because now I think it has gone more than 20 or 30. That's it.
Yeah, I don't know our combined experience at this point, but that was a deficiency in our early report, as we didn't give a lot of guidance for the fibula. And I still don't have firm guidance, but I think pre-fracture, you're basically burning no bridges by performing the hemiepistiodesis. And I agree, you have to treat the fibular pseudarthrosis if present. You have to mitigate progressive valgus deformity. But all of the options for achieving fibular union and stabilization are available to you in a year if the guided growth is successful. And so I would pursue that, at a year or a year and a half, whenever the tibia is sufficiently corrected, assuming it is.
Yeah, another question for the Boeing. Would you consider the extent of involvement? Like many of the surgeons have varied opinion, and as it is no consensus, because I think there are something more than the what we see, because there would be the involvement of the tibia at the lower level or upper third, or sometimes we'll see like the pseudarthrosis. I'll come back to the left side, but if suppose right side is involving entire tibia, does the growth modulation will work exactly the same for all the cases, or it will be different?
In our experience, the growth modulation seems to improve the plane radiographic, ultra structural characteristics. Like we see some recanalization and remodeling with time of a distal bow. But if there's a more osteofibrous dysplasia-like appearance, or there's diffuse lytic involvement, we haven't seen resolution of those. So I know that there's at least one case where we have applied guided growth to the proximal tibia as well. And I think there was an early report of doing that if there really is deformity. So I think that the structural characteristics you're hoping to achieve with guided growth will be seen locally in a distal third pseudarthrosis. We haven't seen resolution of those if it's one of these diffuse ones with very lytic lesions throughout the entire tibia. But if the ankle and knee are parallel, I think that can only be positive for load transmission, even if there are lytic lesions or balancing deformities above that.
Okay, fantastic. Thank you. And then we'll come back on the cases like bilateral involvement, like this cases. How many would be present, and what is your experience on bilateral involvement?
That question is for me.
Yeah.
Yeah, we have performed at least one that I'm aware of bilateral involvement with correction and no fracture. So that's my only experience.
Okay. So it's the left side with the younger patient present with the 4 months of age with fractures. What do you suggest? What do you do?
Question is for me again.
Yeah.
Yeah, so I think this, of course, is not amenable to minor intervention, but the child is still young.
Yeah.
So I would still use a principled approach, and that includes, at my center, we do use pre-treatment bisphosphonates because we know that there's local upregulation of osteoclasis. We also know the hamartoma seems to not differentiate into normal bone. So I would also wait until the child is older so that I can do the operation, but that would include a so-called comprehensive approach with an attempt at a 4-in-1 osteosynthesis or cross union. And so that would include a complete resection of local hamartoma at that level, very little bone resection at the main pseudarthrosis on the left side, but recanalization of the bone. I would perform an acute shortening of the tibia and fibula. There may be a need for another osteotomy proximally, although from these images, it does not appear that there's a large deformity. It's just a large lytic lesion. And then use iliac crest bone graft. I do use bone morphogenic protein in my practice. I have easy access to it, although I know the data is mixed about that across all patients. And then I would use an adjunct for both rotational control and for compression and stabilization. I do like the use of an internal mini fragment locking plate for that control. There is some concern, though, with all of that proximal lytic region that those would not be, good fixation points. So an Elizabeth technique with smooth wires would also be, I think, a reasonable way to give the provisional compression and fixation.
Okay, thank you very much. That, however, the we learn also, and many of the part of India in Vellore, Dr. Risha uses the palmidronate. I know Dr. Pale also uses palmidronate, but yeah, the last year in POSICON in 2024, we have the Jonathan Sumek, and then he expressed that the palmidronate, and he has actually given a lot of talk in POSNA as well, that the zoledronate, because his approach is entirely different than the injectable, the palmidronate or the bisphosphonate in cases with CPT. So would you see the quality of the bone or quality of regenerate or quality of the tibia would be affected with the injectable bisphosphonate?
I don't have any personal experience with injectable bisphosphonates, only with global zoledronic acid administration. So I'd be interested to know if anyone else has any experience that they'd like to share, because I would defer to those who have used it.
Yeah, I think Sandeep can say, and the Thomas can also say, because that they have the quite good experience with the injectable bisphosphonate, because it's varied actually. It's not the same protocol all over the world. So
And
I think
Hitesh,
let Thomas go first, because I think they have a paper. They
Yeah,
have done some
no,
basic science research on them. Thomas?
yeah. So we used a lot of palmidronate injectable for CPT, but after that, Jonathan Shoemaker's very explicit espousal in the POSI 2 years ago, we've actually, our enthusiasm for that has waned. So he actually said it is counterproductive. And I actually got up and actually asked him, see, this is something which has been described by Dr. Pale and by No Choice, the 4-in-1, it's an integral part of our treatment. Till now, you're telling us that this is totally anti, it is not, it is the counterintuitive to use palmidronate in CPT. And he said, well, he sort of backpedaled and said, see, I've done some basic research. It's totally against using palmidronate. So I don't know. He's done some research and he's very strong in saying that palmidronate doesn't work in CPT. So we've sort of climbed back on injectable palmidronate. We used to religiously give every 4 months. So our enthusiasm sort of waned after Jonathan Shoemaker's very, forceful talk. And he's going. So I'm surprised that in Gillette, I thought most of America stopped using Pamitronet.
I think we're all a prisoner of our experience. And so I have some very strong mentors that I've adopted some of their practices. But, you know, the reason for the pamidrate infusion was, at least in my training, to try and mitigate later fracture, which of course is much harder to study, as opposed to just improving the consolidation at the non-union site. And I know that in Florida, they now advocate for it because they think that it can increase the quality of your iliac crest graft. I think that that's an unproven claim, but yeah.
So we have been, using pamitronet as described by Drorpale, where we give, 1 dose of zoledronic acid, not pamitronet, we give zoledronic acid about 2 weeks preoperatively, and then 3 months postoperatively at the time of cast removal. I mean, the explanation, or the scientific explanation given for administration of zoledronic acid preoperatively is that it gives time for the bone graft cells, the osteoblast, or within the bone graft, the zoledronate accumulates, and thereby it prevents lysis of the graft. And we have been using it, but frankly, there is no way of for knowing whether it is working or not. What Pale says is combination of zoledronate plus BMP. So, like, you are inhibiting osteoclasts at the same time you are stimulating osteoblasts. But we unfortunately don't have access to BMP due to the socioeconomic conditions of our patients. We have been using only zoledronate, but frankly don't know whether it is helping in the union or no.
Yeah, Hitesh, before we move on, the Nisar wants to comment. Nisar, please.
Hi, Dr. Georgiadis. I'm Nis. I'm a consultant in Liverpool. I just missed you. I visited Mark Dahl back in February, and I'm so sorry I missed you. I was there for a week and had a great time, and it was very well looked after. I'm actually visiting Professor Shah at the moment for a week in Manipal, so just having a great time. And I just had a question about, you mentioned that you did guided growth in an 8-month-old. I spent a year at the Royal Children's with Stuart Morrison, and we started doing guided growth for pre-fracture anterolateral bowing. We struggled a bit with the implant size in a child. We did it in a 1-year-old. What's your experience of, because the smallest 8-plate that we had at the time was a 12mm 8-plate. So did you use a 2-hole LCP, or what's your experience, sorry, 2-hole recon plate, or what's your advice on doing it in such a young patient in terms of implant choice?
Hey, Nisarg, nice to meet you virtually. I'm sorry we missed you, and I love Stuart down there in Melbourne.
Oh, yeah.
The guided growth, it's such a small operation, but like everything with this condition, it's all small and tedious. So if you're going to do it in a 1-year-old or around that age, I would recommend, an ankle arthrogram, so you could really see the epiphyseal contours, put it as close to the subchondral bone as possible. And then I would get out your mini fragment sets and clip like 1/3 tubular, 2/7 or 2/4 plates. And I often spend some time with the sets before, and I make sure I can remember which screws fit in which plates and don't fall through the holes. So often finding 2/7 cortical screws in a mini fragment tubular plate is what you'd have to use at that age.
Okay, because that's I think we ended up using the 8-plate, and it was just a bit too bulky. But I think next time we'd probably, and we did the arthrogram, which really helped. The other question was, what's the youngest age that you would do a 4-in-1? Like the youngest patient that you would do? It's really tricky to answer, but what's the youngest age that you would consider that operation in a child with pseudarthrosis?
Yeah, so I mean, I would appreciate the opinions of some of my senior colleagues here in the field, but I will do it in a 1-year-old for a couple of reasons. I think that it's physically difficult to do the operation at anything younger than that age. It's difficult to decide about growing rods versus non-growing rods. I know that a lot of people are using the Fossey-Duval instrumentation, and I have been using that as well, but there are lots of fiddly technical complications that can result, especially with a distal pseudarthrosis, more frequent exchanges, bending, if you use an interlocking pin in a non-ossified epiphysis. So all of those things, I think, would push me towards waiting as long as the family will allow. I know there's some historical literature that doing it older for a primary attempt at union seemed to have better results in terms of refracture rates over time. So like this child, if the family is really rearing to go at age 1, I would pursue it between age 1 or 18 months. But if the child can be braced or is comfortable until a little bit larger and bigger, I would accept that and wait a little bit longer. Another consideration is in the very atrophic ones, if they're very hypermobile and floppy, skin issues, you can have that distal fragment come out of the tibia.
Yeah.
I've certainly seen that while we're waiting. So
would you span the ankle with the rod in such a young patient with where the disease is very distal, where you don't have much purchase in the distal fragment, or would you try to preserve the ankle? Would you try and preserve the? Because I've seen lots of, I've seen sort of patients where we've done it, and then we've had secondary deformity, and then in the end, the end procedure has been where you've had to go through the ankle. So would you consider that primarily, or would you try and always avoid that, if at all possible, with the FD?
Again, I'd love to hear what people who have very long-term follow-up on their patients say. I'm trying to spare the ankle because I've seen a lot of degenerative ankles from that. So that would not be my primary, even in a distal pseudarthrosis.
Okay. So I would like to ask the same question to the Sandeep and Thomas. What is the youngest age, Sandeep, would you do that for the surgery, for the established pseudarthrosis?
2 years.
2 years. Thomas?
We used to religiously follow Dr. Benjamin Joseph's advice that you shouldn't, excuse me, that you shouldn't do pseudarthrosis surgery before. I think he went through a sort of a period when he said, I think 3, and then he went to 2, and then he said if there's a fracture, I would intervene between 1 and 2. So we generally used to brace till 1.5, and 2 was our cutoff earlier, but now we have started thinking if there's a frank pseudarthrosis and a fracture, if you're getting the biomechanics right and rodding it at even 1.5 years is okay, is what. So we've started doing it a little bit more earlier now.
Yeah, thank you. And what Andrew, you suggested similar that we used to do the anterolateral bowing in younger child with the mini fragment plate. Actually, we cut the mini fragment plate and make it 2 hole and use the 2.7 or lesser there, and we do the arthrogram as well. The another difference between Indian patient and Caucasian patient, they are small, so the age is actually not the criteria. We see the length of the child and the stature. As it's very difficult to. It's easy to put a rod, but then it will be very thin rod. It will not be very adequate for the fixation. So I personally do around 1.5 year plus, but a child is too small, then I don't mind to hesitate put 2 years also. There is no hard and fast rule for the age, but then when there is a bilateral presentation and there is a gap and the size is too small, I will say about 2.5 years is also okay, but it would be earlier than 3 years. So that would be generally in protocol for the present treatment primary.
Yeah, those are all great points. I don't think there's a recipe that works for all places and all patients. And then also I use a lot of calibrated films. So like I am reticent to make any implant recommendations ever without some magnification marker, because I have definitely gotten into the operating room and realized I can't even pass the smallest, intramedullary device that I was planning on it. And that is not a failure of technical acumen, it's a failure of planning. So these are very tedious, complex deformity operations. And so you need to have, the knowledge of the patient's size before you get in the OR.
Okay. I would like to ask another question. What are the variables? Would you do the same for all the patient 4-in-1? Or would you consider the age of involvement, the extent of involvement, whether it's upper third, middle third, lower third, or you do the same? What is your approach for all the CPT? Would you do the same or would you do different?
And if the question's for me, I would start from the assumption that I would be looking for a 4-in-1 osteosynthesis, because I think there's just enough reports that the cross-sectional area of that union is positive for preventing refracture. I know there's maybe another case that we're going to discuss that was closer to skeletal maturity, and so you may think about that case differently. Also, in the proximal third, I have not done any cross unions really in the proximal quarter of the tibiofibular region. I've seen x-rays of that done. So I think if the compartment can be safely mobilized and you can achieve it without harm, then you would go for it if there's an osteotomy or a pseudarthrosis in that level. But As you approach maturity, that may be less important. That's my
Okay,
opinion.
Sandeep, for the same, would you do for upper third as well? Because I know the
upper third is just, placement of your onlay grafts. I have not dared to do a 4-in-1 in an upper third because the anatomy, mobilizing those compartments, as Andrew said, that seems to be too dangerous for me. So I've done just onlay graft, 2 tibial onlay grafts and tie it around the tibia. That's what I've done for the upper third. Though I have an experience of only one case, but that's what I did for the upper third. Unfortunately, that united.
Yeah, another question for you, Sandeep, where the ankle is there. We talk the sparing ankle or lower third. What is your approach? Would you spare ankle or would you draw trans ankle or go to subtalar or?
No, the last few years that we have started using the cross union, since around 2016, 17 we have always made an attempt to spare the ankle. So the fixation modality initially it used to be an IM rod supplemented with an Ilizarov, but we stopped using the Ilizarov in around 2019 or so, and now we use the IM rod with a plate. Another thing is, what Andrew said about the FD rod. One thing is FD rod in a very young child, it can be difficult to negotiate. Another thing is we don't have access to the original FD rod. We use the indigenous version, which uh, has a very poor, pull-out rate. The pull-out rate is very high from the distal tibial epiphysis. So here, I don't mind even using a non-telescoping nail, a small rush rod, like in a very young child where the medullary canal is small, but then supplement it with a plate and be aggressive about, changing the plate. As the child grows up, just change the extramedullary implant, which is much easier than, changing the entire intramedullary implant. So that's the approach we have been following.
Thank you. And the question to Andrew, because as we say that we don't do about the cross union in upper third, but if we see the child like this, that the entire bone is involved, almost entire bone is involved, more than 2/3 is involved, and there is a procurvatum deformity at the proximal third. Would you consider to do the osteotomy? Would you consider to add the graft? And what is your approach when the entire tibia is involved?
If there's diffuse involvement, and that can be present even if it's not radiographically apparent, I would only touch the areas of the bone where I need to perform a corrective osteotomy or lengthening to pass my intramedullary implants, for example. So in this left tibia, if there's a need to perform an osteotomy in the upper third, I would try to do a closing wedge osteotomy. And then you have a very small intercalary segment. So you want to try and preserve the soft tissue attachments to that as much as possible. So I would try to keep one cortex intact if at all possible. And then I would graft, the iliac crest graft, the osteotomies as well. I think there's always a risk of non-union, but the historical received wisdom was that you should never do an osteotomy in this condition. But my experience, and I think other reports would suggest that there's a high union rate, especially in the metaphysis, especially if you use adjunctive things like iliac crest graft, you're spanning it with your fixation. I think the Baltimore group just published on, elective osteotomies or corrective osteotomies, either with the non-union treatment or as a temporally distinct procedure. And most of those united, like 9 out of 10. So I think you can, and you do need to do that as part of the treatment. You can't have a straight bone without sometimes another osteotomy or two.
Yeah. Sandeep, your experience.
One question I would just like to ask Andrew is, when you have a situation like this, can be seen the left side, where the tibia pseudarthrosis and the fibula pseudarthrosis are at different levels. Any technical tips as to how to put the graft in order to achieve the 4-in-1 union? Or here, would you do something like a Langenskiol procedure, just achieve a distal tibia fibula, synostosis over there, put a screw across the tibia and fibula distally?
It's a great question. I mean, I'm open to technical tips from others too. I find that the distal fibular pseudarthrosis is technically very difficult to graft to the tibia. It's very difficult to mobilize the tibialis anterior. So I would try to, of course, incorporate the cross-union graft from above the tibial pseudarthrosis site all the way down to almost the distal tibial or distal fibular physis. And sometimes I actually find I have to make separate fibular incisions to line up the fibula, to pass the intramedullary K-wire up the fibula, and even to make sure graft is in contact with the fibular pseudarthrosis. So that's all that I have done differently in those cases.
Okay.
Yes, Sandeep, you are right when there are that Andrew's comment is actually correct that whenever there is a both level difference, sometimes we need to do the separate incision. And actually we have done for this particular case and separate incision for the fibula, and fibula grafting was also separate and put intramedullary nail for the fibula for this particular case childs. And this was treated with the anterolateral bowing, and the left side treated with that union on both. Fortunately, it got united, but then we have to revise that because child was too young and grown up. So it's non-telescopic rod. So we recently, a couple of months back, we revised actually. It's quite sound union on both sides, and right side is implant is out. We'll move the second case. It's like this is the similar to the child where there is the extensive involvement of that. Any tips for surgical management? How much we can excise the periosteum? How much we can excise the pseudarthrosis? And what is the technical part for the young surgeon? How they can extend of the excision should extend?
All right, if I'll start.
Yeah.
Yeah, this is very similar to the previous case, except I think more difficult in that there's definitely a proximal deformity, sort of a valgus deformity in the mid-diaphysis that might require an osteotomy. And so all of the other comprehensive approach I would recommend, but I would recommend a wide hamartoma excision, so at least a couple of centimeters above and below the pseudarthrosis that you see, so of the diseased periosteum. And I would only do enough bony resection, especially from that distal atrophic end, so that I could pass an intramedullary implant for some stability. So I wouldn't resect abnormal bone, obviously, and have an enormous segmental defect. So I would probably favor the cross-union type approach with an acute shortening here. And if I could achieve union, then I would deal with the consequences of the limb length inequality later. So the periosteal resection should be greater than the bony resection.
Okay. Sandeep, would you do something differently? Any comment, any suggestion, any?
No, so I will share the experience of a similar case, which, I managed. And it was actually a very humbling case because, before this case, I had done quite a few with the cross union. And I felt that every pseudarthrosis heals with the cross union technique. But this one, I inserted the graft, and within almost 3-4 months, the entire graft just vanished. And later, this child took treatment with Dr. Sandeep Patwardhan, and what he did was he just exchanged the rod. And I have a very interesting follow-up X-ray on this child as to what happened is the distal tibia and fibula healed. So there was a distal synostosis between the tibia and fibula. So there is a rod going from the proximal tibia to the distal tibia, and there is a gap in between. So despite this, now the child is walking full weight bearing, and it's almost a 4-year follow-up. So we are just keeping that under watch. So, but this kind of X-ray picture, I must say that the disease is pretty malignant disease, and there is a high chance of graft resorption. When you see an X-ray picture like this. In fact, this child, I had the serial X-rays from birth, and it started off with a simple anterolateral bowing, looked like a very routine CPT. But by the age of 2 years, this X-ray picture turned to something like this, and that tells you that the disease is not your routine CPT that you are treating.
Yeah, that's the same question I was about to come. That while waiting, that we also found that the disease, what is not visible on X-ray initial part, that will be visible later. So because we say it is a tibial dysplasia, we'll not say tibial pseudarthrosis or anterolateral bowing. We'll see only the visible part, but the entire tibia spectrum is disease, not the normal. So I think we need to take care, and message is there. So anywhere that fracture can happen, not at original site, above, below, and at the proximal third also. We have seen also. And if the tibia is not protected, it can lead to the deformity in all the direction, procurvatum, recurvatum, valgus. Very common to have valgus, ankle valgus. It can happen. And that is the reason we need to protect with the intramedullary rodding. But the technical decision, what you said, that when we do exercise a lot, that how would you compress it? How would you maintain that compression in such case? Because you mentioned atropic part, and we have to take out because it will not be viable part. But how would you maintain that the compression? Would you add anything?
Can I say, Professor Shah, would you consider an Ilizarov here to maintain compression? Because I think a simple two-ring all-wire Ilizarov with a proximal ring with
a question. How do you maintain? Because Sandeep said the plate. So I'm saying, Andrew, would you do the external fixator?
I go into the cases wanting to do a plate because I've been satisfied with my early experience with the plate. But in this widespread dysplasia in both segments, that would be a risk, of course, for failure fixation. I think the same types of risks exist with smooth wires. Those can become lytic and loosen over time. But I think you'd have more confidence in some smooth wires just subphyseal proximally and distally. So that I would consider a simple Ilizarov frame in this case. Yes.
Okay. Sandeep, you are doing from the Ilizarov to plate. Would you consider plate or the ring?
I think, retrospectively thinking, I think it would be a good idea to keep the Ilizarov on table. But I would first, try to put in the plate. The problem is the hold, the screw holds. And, sometimes even if you are using locking plates in this type of bone, you may not get the hold, in which case, I may change my decision from a plate to an Ilizarov.
Okay. Yeah, this case also, fortunately, we did in not added into plate, but it's united actually. This child also united, but we're fortunate. It's not that something great on that, but
just a rod.
Yeah, just a rod.
Okay.
Yeah, we'll move on to the third case. That's the complex case. It's been operated by one of the young surgeon, and this one attempted is the pre-op X-ray was similar to the last two X-rays. There was deformity. They tried to do the correction. Unfortunately, the child developed the rod back out, and then they pulled the rod. So now presented with NF1 with the segmental involvement. So this is the case has presented exactly at 1.5 years, 1.3 years. So what should we do?
If I'm starting, is it any infection or suspicion for infection?
No,
I would
now there is no infection. All the markers are normal. Child doesn't have any post-discharging sinus. No sign of infection. CBCS are normal. CRP is normal.
Well, I think there are a few ways to approach this. I would probably approach it in a similar fashion to those previous left tibias as well. You have two definite non-union sites. They aren't purely atrophic, like there is some callus. There's this diffuse cystic involvement of the entire tibia. So I think the comprehensive approach makes sense, and you're going to need two now healing pseudarthrosis sites. The fortunate thing is that it looks like those are the only sites of deformity. And so I think that an anterior closing wedge type osteotomy after hamartoma resection distally, and then a slight medial closing wedge osteotomy of that pseudarthrosis site proximally, very careful maintenance of whatever soft tissue to that intercalary segment, and very careful creation of a canal of that segment. I think that's going to be a very tedious thing, but I would try to preserve all three segments at my reconstruction. And I think that I would probably utilize the plate fixation, although the same discussion applies. Dysplastic bone, anything you do may become a lytic hole. So it's either plate fixation or an Ilizarov for compression. So I think I would approach it similarly. I'm interested to know what others would say.
Yeah, Sandeep.
Yeah, another point that has to be, seen here is what is the viability of the middle fragment.
Yeah.
Okay, because, it is very difficult preoperatively to assess. But intraoperatively, you may get an idea: is it bleeding bone? Does it look sclerotic? And if it is non-viable, okay, then one option which we have pursued in one case is a mescale over here. First stage, just put in a cement spacer, and second stage, take out the spacer and do a 4-in-1 kind of procedure. Put a fibula in the intervening gap and then cover that over with a barrel, ilia crest all around the tibia and the fibula. So take the fibula, use fibula from the opposite side to bridge the gap in this tibia, and then do like a standard 4-in-1 around that fibula. So that is one option. We did it in one particular case, and that fortunately has healed. So that is one option if it is non-viable. If it is viable and you can preserve that bone graft, then I agree with what Andrew has said.
Sandeep, may I ask, did you do an induced membrane before that fibular graft? Did you do a 2-stage, or you did the fibular graft?
Yeah. So we put in the cement spacer, and then we went back in after about, I think, 4 weeks, and we replaced that cement spacer with the fibula and bone graft all around.
Yeah, another challenge what we face here is that the canal on middle segment. So the canal is like, it's very difficult to pass, and if we template the central fragment, it's very narrow. So the very hardly get about 3 mm rush rod or 3 mm rod, which is going to provide very less stability for the fixation board on either side. So any idea, or anybody will be thinking about Huntington or the tibialization of the fibula?
Yeah, that's what I was going to say, Hitesh. Even for the previous one, we've hardly ever put. Have you started putting plates for CPT? Because we've never.
No.
Thank God. Because I was just thinking whether I've become outdated.
No,
after
not
Benjamin.
outdated. Thomas, sorry, I miss you. Sorry. I need to take you.
No,
Dhiren, you want to
because
say something? Yeah.
no.
Thomas,
So even in the previous case, for any case in Velo, we actually go back to a tried and tested radical debridement, retrograde rush needling, if it's in the distal third, or antegrade rush needling of the biggest size, just like Professor Joseph said and espoused. And he always, actually in the beginning, never used to put a wire for the fibula. Of late, towards the end of his period, I think in Manipal, he agreed that we should also start stabilizing the fibula. So we've also started putting K-wires for the fibula. So only even if it's multiply operated 2 or 3 times in the pictures like this, our fallback option is to go back, radically debride, put in a rush rod, either if it's retrograde from the distal third or distal fourth if it is there, or antegrade if it's in the proximal half, and with tricortical dual onlay graft. But if the fibula is big and sufficient, we sometimes bring it to the debrided side to fill in that gap, like an ipsilateral pedicle vascular, meaning not a vascularized, but an ipsilateral transfer of like a Huntington's procedure. We'll consider. That's what we do.
Yeah, Hitesh, I have a question. Like, say, your approach is to use a contralateral tibia. Now, when you have to breach so long like segment, how will you make it cover the 3 sides of the pseudoarthrosis?
Yeah, generally we take into if we say the size, we take it from almost to up entire the length of the tibia, and we put it into separate piece. So if this size is there, the size would be adequate to cut into the 4 or 5. So we can put half on the proximal side, half on the distal side. And what the Sandeep and Mandar has stood that, we always use that actually, what they have presented in post-C, we always wrap all the tibia. They never put only on one side or 2 sides. We all around. What Thomas has made a point, at the pseudarthrosis side, we never put only in 1 or 2 side. Not dual only. They always say dual. We put all wrap around. All wrap around, not only the one place.
That's right.
Yeah. So I had a question for the Thomas also. Would you consider only cortical graft or corticocancellous graft?
No, only cortical graft.
Okay. So Andrew, we used to do the cortical graft. So then that is reason it is very important that the palmitoronate or injectable zoledronate was there. The reabsorption, what Sandeep said, that the absorption of graft was very common in cancellous or like iliac crest, which is cortical would be more resistant. So it will take time to resist. So we had all the cases without the bisphosphonate, but then was a lot of controversies on bisphosphonate. There is no right or wrong, both are correct. It's, I think, like in a way that, but we were discussing the options, like a central part, how to deal with that fibula or ipsilateral fibula canal. And as Sandeep said, there is no one answer for these cases because there all are the options are correct and all are wrong. Turn out to be a problem in this case.
We had a case similar to this one in Alderhay, and it was a slightly older patient and operated on multiple times and had a non-viable middle fragment like this. I think he was a 6 or 7-year-old, and we opted to do transport. So we basically excised the middle fragment, had a big defect, I think of 6 or 7 centimeters. We then transported. We got good regenerates, but then it failed to dock. And then we had persistent non-union at the docking site. We had to have multiple trips to theatre to achieve union. And in the end, we had to actually send this patient to James Fernandez, who then basically revised everything and did the 4-in-1 and managed to achieve union with the telescopic rod crossing the ankle, because what was happening was there wasn't enough stability in the distal fragment, and in the end, now this patient has finally united. But we just had one negative experience of transport with a non-viable middle segment for these kind of ones, so they're very tricky.
Yeah, you are telling something? Yeah, go ahead.
I was just going to agree with the intuition there. I mean, all of the problems about union fixation, lysis around pins with a more prolonged treatment like a transport for this patient, I think there'd be higher risk for complications. So I would not proceed with that as the index treatment for this situation. Yeah. Yeah.
I do agree with Andrew, because if you see carefully, the disease is extending to the metaphysis and proximal. Proximal fragment is also not normal. So if we do lengthen or transport that generation, that quality of bone also would be same. So it's not that only the middle segment will take out. If you do the regeneration or the alizar or transport, we'll face the difficulty in a docking site in this particular cases. It's not right and wrong. So all options are correct and all options will met with the complications. So we'll move on the next case. That's the older patients. 17-year-old patient presented with deformity and pain at the middle third side, and he has got the 6 centimeter shortening. So in such cases, or the question is there, up to how long, what age we should do the same approach, and when should we change our approach? Or would you treat this patient with the same with the previous one, or something different?
I can respond first. I would approach this patient with the same principles in mind, my concerns about the local healing environment. So I would approach the non-union with a similar debridement and preparation of the canal, a fibular osteotomy, and I would acutely shorten to compress. But I would do a lot of planning to see if I could do this with some other implants as opposed to some of the techniques that we've been using thus far in our discussion. So I would probably do 2 things preoperatively. I'd obtain a CT scan to really look at the inner cortical dimensions of this canal to see what I could fit inside this tibia. And I'd also really see if there's just a uniapical deformity as it appears. It appears that we could do a correction of deformity with just one apex. I see some lytic appearance in maybe the distal metaphysis, but not a large deformity. And so if that was the case, we could just pursue 4-in-1 osteosynthesis. I think that would be reasonable, but I would also consider placing an intramedullary magnetic lengthening nail, that if it was sufficiently large enough, I could deploy that nail 2 or 3 centimeters. The nails here are 8.5 centimeters in the larger portion, 6.5 centimeters in the telescopic portion. I could acutely compress intraoperatively and then acutely compress postoperatively and maintain length, alignment, rotation, good stability. So that would be a different way of thinking about this near mature pseudarthrosis.
Okay, thank you. But however, the magnetic rod is very exuberant and costly in India, so it's just out of consent. So I will ask Sandeep. Sandeep, what will you do?
17-year-old, right?
Yeah.
It's a difficult one, but in the first stage, what I would do is I would just, not combine the lengthening with that correction of that anterolateral bow. Okay, first stage, I would just do an osteotomy and bone grafting at that site, kind of 4 and 1. Having said that, generally these types who have not fractured till the age of, skeletal maturity, generally, even if you do an osteotomy, they don't give a problem in union. And once it is completely solidly healed, then I will take a call regarding the lengthening. Regarding the lengthening, there are studies which I don't have much experience with that, but there are studies which have shown that lengthening in the same tibia, they do they don't give that much problem with consolidation of the regenerate. So that is one factor. But another interesting thing that we have noted in some of our cases is that many of the CPT kids, they have a tibia shortening on the same side, but they also have some amount of femoral lengthening on the same side. Okay,
Yeah.
so the knee is anyway asymmetrical to start with, and in that case, if the femoral asymmetry is also about 3 centimeter or something, we can even consider lengthening of the the femur in that case. Okay, something like that.
Yeah, but Sandeep, what we have also noticed in our long-term follow-up, when there is a tibia shortening, compensatory femur would be longer. So if you do
Exactly. Sorry. Yeah, I confused the thing. Yeah,
Yeah.
the ipsilateral femur is longer than the
Yeah.
contralateral femur, and
Correct.
the ipsilateral tibia is shorter than the contralateral.
Correct.
So you will need to lengthen the tibia, though I don't have any first-hand experience with that. But I think what the studies show that lengthening in case of CPT, it is quite the results are quite okay. I don't think it is that much of a problem.
Yeah, but Choi has given a very nice article in JPO. What he mentioned that's the quality of the bone where you do regenerate, metaphyseal sites, previously untouched side, the not entire involved tibia, they do very well. But if there is a deformity, involvement of tibia, repeated surgery, repeated any surgery before, they don't do well. So there are the variables we need to consider, and this is untouched tibia. So as you rightly said, is untouched tibia most likely to get good result at the fracture side and proximal also, it will be fine. So the important aspect is that canal. That's when the canal, as Andrew has suggested, that we are finding it difficult to find out the exact size of the canal, because it's choosing the appropriate size road will be very, very challenging in such cases. However, the Sandeep, would you do it external fixation? Yeah, Andrew, you want to say something? Sorry.
Yeah, I was going to ask what your approach would be. I would probably use the expensive rods, achieve union, and then do a metaphyseal corticotomy later around the rod. But the same approach could be used with a frame. I'm wondering if people would stage the length and the union surgery or do them together.
Yeah. So
exactly. Don't combine both in one stage. First finish off the anterolateral bowing and then go on to lengthening at the proximal metaphyseal level.
So Andrew, when one more question for here, when the fibula is intact, how would you choose to do the osteotomy? What level, when, how much, and what are the factors to consider for how much amount of shortening of fibula? Would you do the tibia, come back on fibula, or you do the fibula first or later? What are the technical tips?
I think that to affect the deformity correction at the tibial apex, you will need a fibular osteotomy at the same time as the tibial non-union procedure. And so I think your options there would include simply allowing them to overlap. And if the tibia is not involved, that might heal. I've seen certainly that. You could also perform your tibial correction and fixation and then see how much fibular overlap you have, resect, and then do intramedullary fixation and bone grafting to the fibula. I think those are two ways to approach it.
Okay. So, and Sandeep, would you do about internal fixation or external fixation in such case?
No,
Along
that
with
the anterolateral bowing site, I would do an internal fixation. And obviously,
Okay.
the lengthening would have to be with an external fixation. Elizaro probably. Yeah.
Yeah, so what we have seen and what we do in the second decade, the child is older, the rod will not give the good rotational stability. What Thomas was telling, that the older patient, we always add the something it will give rotational stability. So either we can add X-Pix or along with the intramedullary, we'll add the X-Pix or the plate. But this case was treated with the intramedullary nail and external fixator. The external fixator removed after 3 months, it got united. He can ride the bike, but he did not want to do the length correction. So he's mature, he's got maybe 10 years follow-up. He's riding the bike, but with the 2-inch sole raise. So that is common on that. We'll have one more case, maybe the last case. This is the anterolateral bowing, as we discussed the first in anterolateral bowing. Would you consider this is the Crofall type 4, Frank pseudarthrosis, or type 1? What would you consider this patient? Younger child, 6-month-old child. Would you consider as fracture or no fracture?
Are there any symptoms?
Bowing, deformity, that's all. No, the child is not walking. So it's 6 months. So it's either way, not at that age.
I don't see a discrete fracture at this point. So even though this is diffuse cystic disease, I don't think it's a Crawford 4 atrophic non-union. So I think it's still in a pre-fracture state. So that's how I would approach it.
Okay, Sandeep?
Yeah, I agree. There is no real fracture visible. So at the moment, I would just, apply clamshell orthosis and maybe just apply the anterolateral 8 plate. Would you do it, Andrew, in this particular case?
I think there's very little to
It's
lose.
quite proximal and extensive disease. Yeah.
Yeah. I think there's very little to lose, very little potential harm, although he looks like he might be too small to do it. But if we can keep him unfractured until he's approaching 1, I would consider that. Yeah.
Yeah, thank you. Thomas, what you will do? Because Thomas.
No, we just will brace this child. This is the cystic type. So we'll brace. We have very little experience with the anterolateral plate epiphysiodesis. And like the problem in technically putting a small plate in the ankle we face. So we actually struggle to put in a mini fragment like Andrew said. So we'll probably brace and wait like in the pre-fracture state.
Yeah. The one last question to the Andrew, would you change the plane of correction with more anterior bow or more lateral bow in anterolateral bowing?
For the guided growth treatment, we have a very old school approach where we get out our paper and we actually calculate the oblique plane of the deformity. And to the degree you can, intraoperatively, we try to put that in place. If it's a really pure, just lateral varus bow, you can't really put it in the tibiofibular region. So it ends up usually being 30 to 50 degrees from the pure sagittal plane. But we try to get an intraoperative fluoroscopic image of that distal segment to make sure that our plate is in that plane of deformity, if that makes sense.
Yeah, why I asked the question, because I visited Dr. Alvin Crawfall, and Alvin Crawfall never published the paper on anterolateral bowing. What the Jennifer Len and Mark Dull has published in JBGS, he used to do the screw actually, because he said that when, as you rightly said, pure lateral plate is very difficult because fibula is there. The posterior is very, very difficult. So what Dr. Crawford used to put one screw, like a Matizio. But the problem, he never published that, but I have seen him. I have seen his physically that he is to put with the Matizio, but I don't know how many series and what number, and he has shown the result. So, but that is reason that the deformity is all different. Anterolateral bowing is not same. All are different.
Yeah. I mean, I suppose that could work. It's such a small epiphysis. You don't get a lot of purchase with a screw. And I would try not to touch that physis at this young age if I could avoid it. But
thank you very much for your time. I think his time is done. So I'll ask Dr. Dhiren Bhai. Dhiren Bhai, you want to say anything? Please.
So just I would like to thank all the faculty, Dr. Andrew, Dr. Sandeep, and also this Serg for contributing to this session. And yes, Thomas. So the message I would like to give to the fellows and the young pediatric orthopedic surgeon is like, we can see that none of the experts agree on a particular point in most of the situation. So there is always more than one way to skin a cat. And it's always up to you to decide the best treatment which works in your head. So with that, I thank the faculty, experts, and our participants to join this session. Thank you very much. And bye-bye.
Thank you.
Thank you.
Thank you.
Thanks.
Thank you very much.
Wonderful. Thanks.
Thank you.
Thanks, Atish.
Thank you.
Hitesh, it's nice to meet you. I've learned a lot from
Nice
your
to
work.
meet
So
you. And hope to see you
wonderful to hear you
physically.
speak.
Thanks. Thanks.
I hope so too. Be well. Good night.
Thanks. Thanks.
Send my regards to Dr. Dahl for me, Dr. Georgiadis, when you see him, and Dr. Nam.
I will. I hope we can cross paths.
Likewise. Cheers.
Cheers.